Good afternoon, ladies and gentlemen. Welcome to the CHSRF On Call. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press star and then 0. Web participants requiring support should select one of the tech support options at the bottom of your screen. I would now like to turn the meeting over to Stephen Samus, Vice President, Programs at CHSRF. Please go ahead, Mr. Samus.
Thank you. Hello and welcome to CHSRF On Call, an interactive series by the Canadian Health Services Research Foundation. CHSRF On Call brings together policymakers, healthcare executives, researchers, and you to be part of a dialogue about ways to improve healthcare for Canadians. We're also pleased to now offer new and improved connectivity options for the entire audience on the call today, including new web streaming with integrated audio and video, allowing participants to listen through their computer speakers as well as simultaneous interpretation for our French language audience. As you heard, if at any time during the call you experience technical difficulties, please choose one of the tech support options at the bottom of your screen. And also, as you heard, my name is Stephen Samus. I'm Vice President of Programs here at CHSRF. And I'd like to again welcome you to the call where we're exploring public policy and Canadians' attitudes toward the healthcare system. This call originated from a synthesis that CHSRF commissioned Stuart Soroka to do, which really synthesized 10 years of Canadians' attitudes towards healthcare. And as we all know, that's a topic that's always at the top of Canadians' priorities, is our healthcare systems and our experience of them. We're very pleased to joining us today are Stuart Soroka, Associate Professor in the Department of Political Science at McGill University, and Ian Brodie, Strategic Advisor at the Inter-American Development Bank in Washington, D.C., and former Chief of Staff to Prime Minister Harper. Today's call begins with brief presentations from each of our speakers, and then we'll open the lines up for a question and answer period when we'll take questions from the audience. Instructions for asking the questions will be provided at that time. It's now my pleasure to hand the floor over to Stuart.
Thank you very much. So I'm going to try to be relatively brief, but cover a kind of broad range of analyses that we've conducted over the past year or two. I think the objectives of the presentation are, I hope, pretty clear on this first slide. I won't list them out loud then. Rather, I'll note that there are really two ideas that I want to highlight today. The first is that one characteristic of Canadians' attitudes on health that is commonly seen as evidence of inconsistency is in fact not that at all. When you ask Canadians how they feel about current levels of care, they're largely positive. When you ask them about the system in general, they're largely negative. This isn't purely evidence of media-driven skepticism, even as everyone is getting good care from physicians. And one of the things that I want to emphasize today is that believing that things are currently good, but that they may change for the worse in the future, is totally reasonable. And if you buy that, then it looks more like Canadians' attitudes about the healthcare system are meaningful, that is, rational, and that makes them a useful tool for policymakers. The other thing I want to emphasize, and note that this is related to the first thing, is that those of us working in the healthcare field, and indeed those of us working on public attitudes on policy more generally, would do well to learn from the literature on economic sentiment. In that literature, it's common to distinguish between attitudes about the past and attitudes about the future, between attitudes about your own situation and attitudes about the situation in the country generally. And applying that typology to attitudes about healthcare can be very revealing, as I hope we'll see below. And so we can move on to the next slide, please. First, though, let's kind of set the context. This slide makes clear the kind of situation in which we're currently working. This is a trend in Canadians' healthcare policy mood. That is, their mood about the healthcare system over the past 20 years. Now, getting to that one line takes a lot of work. There's no single survey question that is, that's asked that consistently over time. And mood here is based instead on a wide range of survey questions, literally hundreds of survey questions across numbers of different polling firms. It's based on an algorithm that extracts the underlying trend from a diverse body of survey data. And the math here is less important than the trend, of course. What we see here fits with what we might have expected, I guess. there's a kind of general decline in assessments about the current state of the healthcare system, leading up to and just past the time of the Romano report. And from about 2004 onwards, there's gradual improvement in assessments. So it's important to remember, as we discuss healthcare reform today and Canadians' attitudes today, that Canadians' assessments of the current system are not currently all that bad. At the same time, it's important to remember that these are attitudes about current levels of care, and that attitudes about future levels of care, kind of prospective attitudes, are rather different. We can go to the next slide, please. So this slide makes somewhat clearer what I mean when I'm talking about distinguishing between past assessments of care and future assessments of care, and personal levels of care versus system-level levels of care. We would talk about egotropic personal and sociotropic system level sometimes. So you can see here we have our kind of grid of the 4 different types, and these are all questions that we actually have fielded in the past month. And so you see in the top left, we're looking at how you feel about the health care you receive. That's a kind of current and past assessment. If you look below that, you can see we're talking about the health care you and your family may need in the future. And we can contrast those questions with questions that ask about the system in general. What do you think about the last 5 years of the system in general? And what do you think about the system in general in the future? This typology is regularly applied in the economic realm. We regularly ask, that is, those people working on economic assessments, regularly ask about your own personal finances and about the country's finances, about your finances over the past year or two, and about the country's finances over the coming year or two. And I think that's a useful typology to apply in the healthcare domain as well. We can go to the next slide, please. So it's important to note here that the questions do get different responses. We're not kind of tapping into exactly the same attitude over and over again. And so here you can see the distribution of responses across each of those 4 questions: past personal, future personal, past system level, and future system level. And this is as of last month. And so what's most striking here, to me at least, is the proportion of respondents in the good sections, the blue and green categories, in the 2 questions on the past, versus the proportion of those respondents in those categories in the 2 questions in the future. Clearly, Canadians are happy thus far, but concerned about the future. It's also worth noting that moving from personal experience to system-level experience can result in a drop in assessments. So, for instance, past system-level assessments are worse than past personal assessments. In a nutshell, we think that we're getting reasonable care, but that others may not be getting the same level of care, and that everyone's care will be worse in the future. You can go to the next slide, please. Those results aren't an anomaly, these kind of results from last month. We can see the same increasing gap in attitudes when we look at trends in survey questions over time. And so this slide shows 2 trends in questions, where the left panel shows responses to a question about the overall quality of healthcare services available to you and your family. And the right panel shows responses to a question about services in your community getting better or worse in the future. We see increasing personal assessments, that is current personal assessments, and decreasing assessments about the future. So they're moving in different directions, and so the question then is why? And my answer comes in 2 parts. First, our attitudes about the healthcare system are driven by a combination of personal experiences, that is by ourselves, our friends, and our families, and extra personal experiences, that is the experiences and attitudes of unknown others, mainly through media content. And, moreover, and here's part 2, different components of our healthcare attitudes, that is past versus future, and personal versus system level, are affected more or less by varying combinations of personal experience and extra personal experience. Next slide, please. So here's an example of the impact of personal experience. There's a big multivariate estimation behind this figure, but the important part is I hope, relatively clear. Waiting for care tends to decrease individuals' assessments of the state of the healthcare system. This is particularly true here when we look at waiting to see a doctor or waiting in an emergency room. In short, if you wait for care, you are less likely to express confidence in the healthcare system. So your own personal experience, and actually in the larger analysis of which this is part, we found waiting times in particular matter to levels of system support. Go to the next slide, please. At the same time, there are clearly connections between the content of debate in mass media and survey respondents' attitudes about healthcare. And here we can see kind of two trends. The trend in articles. This is based on a database of healthcare articles in major Canadian newspapers. We can see the trend in articles that focus on crisis in the healthcare system, and the proportion of respondents believing that the system is in a state of crisis. There's a strong relationship there. So, in a way, media content has to matter here. When we're asked about the system generally, we clearly aren't being asked to rely exclusively on our own experience. We're being asked to make a more general assessment, and so we rely on a wider body of information about the state of healthcare, which in many cases must come, this kind of extra-personal experience must come from media. Go to the last slide, please. The end result, I think, is that policymakers must try simultaneously to deal with individuals' attitudes about their own care and their perceptions of the system more generally. In essence, it's not enough just to improve the quality of healthcare. Ongoing system support is driven in part by prospective concerns, and the relative weight of personal versus extra-personal experience is likely to be different for those prospective, forward-looking assessments than for backward-looking personal ones. Media content may matter more, for instance. Communication, that is, may matter more. Now, that doesn't mean that forward-looking concerns are unjustified or irrational. By many measures, the state of the Canadian healthcare system is actually in a state of decline. So it may be that extra-personal experience, that is, what we experience through media, accurately captures the state of play. Our own experience is still largely good, but there are signs of decay, and what we learn in media suggests that that decay is real. So we are currently content, but prospectively nervous. That, I think, is how I would characterize the current state of affairs, where Canadian attitudes about healthcare are concerned, at least. And perhaps I'll stop there and turn things over to Ian.
Stuart, thank you for that. I'm going to speak not about an overview of public opinion, given that Stuart's covered that better than I could, but to speak to some experiences I had on the health policy side from my time in politics. I should say at the beginning that these are personal views. It's true I work now for the Inter-American Development Bank. I don't think they have any view on this one way or the other, so it's not a view of theirs, but it's also not a view of my previous employers. And my focus here is on timeline from when Mr. Harper and I were in opposition. I make it a policy of not talking about the machinations of what went on when I was in government. But my work here in opposition is in the lead up to the 2006 election campaign, the election campaign that first elected Mr. Harper to government. The campaign platform that we had put together for that campaign included as one of its featured pieces a health policy item related to a patient wait time guarantee, and I'm going to speak a little bit to the background of that. The points that I want to speak about are the ones listed here, although not quite in this order on the slide. From my perspective, certainly dealing with the health policy issue from the government side, the federal government side, we work in a rich data environment. There is plenty of public opinion evidence available in Canada, both in the public realm and privately held by the Government of Canada, about public opinion views about health policy and health system performance over a very long period of time. Not entirely driven, but in the case of the federal government, largely driven by the substantial amount of money that Health Canada has committed to public opinion research over time. Public opinion on health policy frequently starts with public assessment of how anxiety about or concerns about the health system show up in people's personal opinions of the public agenda compared to other issues, but I want to talk a little bit more about that. From my experience anyway, this I think builds on Stuart's data. Everything I ever saw was that people's perceptions of their own interaction with the healthcare system were strongly rooted in their own experiences with the healthcare system, and therefore people's personal perceptions of problems and successes in the healthcare system did not fluctuate as sharply over time as other assessments of other aspects of government programs did, where they may or may not have had the same kind of very personal experience. People's assessments of general economy and job performance over time may or may not be connected to their personal experience. Almost everybody has some kind of personal encounter with the healthcare system in Canada. Therefore, people's views of the performance of the healthcare system vis-a-vis their own health tend not to bounce around over time as much as the case of people's perception of other government performances. We were dealing in an environment of very depressed expectations about what governments are capable of doing as far as health policy and health system performance over time. In particular, a discount that the federal government is capable of moving any aspect of the healthcare system very directly over time. And then a very profound trust deficit, in particular, as far as our party was concerned. Could I have slide 12, please? I want to start with the trust deficit because this was the biggest hurdle that we had in dealing with this during the 2006 election campaign and then through my time in the Prime Minister's office. Not just a profound trust deficit of voters towards governments, which is a general phenomenon, and of health care consumers vis-a-vis government providers over time, but in particular, Canadians had strong and enduring views of how the different federal political parties lined up in their trustworthiness for dealing with health issues. And there's no question the Conservative Party was, certainly in 2006, was at the bottom of the hierarchy. The Liberal Party had a strong national attachment in people's minds to success of the healthcare system over time. There's a high level of voter trust with the Liberal Party dealing with health policy issues, to a lesser extent with the NDP by virtue of not having been in government, I assume. And then a strong suspicion that the Conservatives had bad ideas in mind for the healthcare system, that there was some kind of hidden agenda at work. And a strong anxiety about reduced access to healthcare services in the future. This was, I think, reinforced by, other than at the very top line, policy unanimity amongst all the parties about the future of Medicare in Canada, a policy vacuum below that level as far as precise details about what was going to be done. So I have slide 13. When I say that we found that health issues were frequently top of mind when people were thinking about the political agenda, over the course of the past 15 years or so, if you take the most generic questions about what issue do you think matters most in federal politics today, different polling companies and different polling organizations have different ways of asking that question, but there's a similar question involved in most political surveys. Healthcare and healthcare policy issues are frequently the top-of-mind issue, but that itself is not a very revealing statistic. We had certainly found by the time of 2005, 2006, we were putting together a platform for the 2006 election campaign, that although health continued to be the number one top-of-mind political issue for the federal political agenda, that its margin over economic issues and local crime issues and so forth had declined remarkably in the previous 5 years. As in the early 2000s, it would be quite common to see healthcare named as the number one political issue by more than half of the people in a national sample opinion poll. But by the time we were working towards the final stages of the 2006 election campaign, that had declined remarkably into the sort of 15 or 16% range. So healthcare, although it was statistically still at the top-of-mind issue, was not by a very large margin over economic issues by that point. I think we'd come to the point where healthcare was, in effect, a default option. And you asked people who had no particular view about what was the top-of-mind issue, that healthcare had become a default option, and we were down to a very small segment of the population that said that, still larger than people whose top-of-mind issue was economic issues or some other crime issues. Could I have slide 14? Reinforcing Stuart's comments, we also found that people's views of their involvement with the healthcare system were strongly driven by their own experiences, and in particular, to go to the very extreme of Stuart's slide on this, beyond people who had to wait more than a day to find to get access to a family doctor, people who had no family doctor of any kind, who were entirely dependent on drop-in clinics or other kinds of informal arrangements, had extremely dire perceptions of the quality of the healthcare system from their own personal perspective. And when we started to unpack this, it turned out that the folks, a substantial chunk of the population who had no regular family doctor of any kind, we're talking about 15 or 20% of the population, and the composition of that slice of the population was trended to be a lower middle income group or a lower income group, slightly less than average national average levels of education, people who were in blue-collar occupations or had not a strong continuing attachment to the labor market. We were interested in those people, that pool of potential voters for a variety of reasons as potential conservative voters. We had other parts of the 2006 election campaign that were intended to tap into those voters. Many of them tend to be non-voters. A large number of them just don't connect to politics at all. And one of our other objectives I can get into if people are interested in the question was to try to pull non-voters out of the non-voting population and to recruit them into the political process, at least on a one-time basis, to vote conservative. The 2006 election campaign was the blip up in turnout rate of the declining turnout rate in federal elections for the last 25 years. It's perhaps not surprising that this was a measurable part of the political population that was of interest to us, given the other numbers we've seen of the size of wait lists over time for different kinds of medical procedures. I think what surprised us was the number of people who simply felt they had no permanent attachment to the healthcare system at all, and then very few or very diminished expectations of any kind of real improvement or change over time. This led us to, if I could have the last slide 15, federal promise in 2006 to pursue a patient wait times guarantee. Obviously, this had come out of a series of Senate committee reports over the course of the previous 2 years, starting in 2004. A fair bit of the intellectual work was done by a bipartisan group of senators in the Senate. It had the strong advantage to us of speaking to that portion of the population that had either no particular continuing contact with the healthcare system in the sense of having a regular family doctor that they saw, or people who had deep personal experience with profoundly long wait times for particular medical procedures. It was, in a certain sense, a readily comprehensible promise in the sense that we were driving at people who had profound cynicism towards politics, a detachment, generally speaking, from the political process, and who didn't believe that there was anything specific that could be done to improve the healthcare system in Canada from the federal government's perspective. We tried to make as concrete a promise as possible. I won't go into all the reasons why this didn't go as far as we had expected. I would just note that since we had written the platform in anticipation of winning a majority government, we didn't have a majority government at that point in 2006, 2007. That probably played a role in it. I noticed, though, in the Alberta provincial election of March and April that wrapped up at the end of April, the Wild Rose Party, which was in similar strategic position to ours in 2006, made a very similar promise, differently conceived of because they're running a provincial level campaign, and the province obviously is closer to most of the sort of retail level of the healthcare system than we did. And it's unclear to me whether they had gone through any of the after-action exercises that we went through as to the pros and cons of the promise. Obviously, Wild Rose did not do, I don't think, as well in that election campaign as they had hoped, but nonetheless, they put together a coherent platform and a coherent, I think, political coalition that supports the 20 seats they won in the provincial legislature. We'll see if that kind of promise comes back again. I think overall, the level of anxiety about the healthcare system, as Stuart pointed out, at least people's current experiences with it has declined over time. Levels of general satisfaction with access to healthcare services has no doubt improved since about 2004 or 2003, depending on the time series you're looking at. And this could also be feeding, I assume, the federal government's retreat from using its financing position within the healthcare system to try to drive other broader reforms, including even the wait times guarantee that we ran on in 2006. Stephen, that's all I have.
Wonderful. Thank you both, Stuart and Ian. Terrific talks. We're now going to open up the floor to the audience for questions. There are two ways you can pose your questions today. You can submit them electronically using the questions box located on the bottom left of your screen, or for those participants not connected by computer, you can ask your questions verbally by pressing *1 on your touch-tone telephone. When asking a question, we ask that you please identify to whom the question is addressed, and please try to only ask one question at a time. And we do have a question here from Irene at QP. A question for Stuart Soroka. Stuart, what are the opinion trends regarding for-profit versus public non-profit delivery of health services, or privatization, whatever aspects you've studied?
So that's a tough question because asking questions about private healthcare in surveys is quite tough. So it isn't that there's a lack of data, but it can be hard to interpret what polling firms and then what respondents think of as private delivery in healthcare. And all of you will be experts on that, far more so than I. While there's a huge pile of data, it's hard to get a sense for exactly how people feel on the privatization of specific things, specific parts of the system, that is. Having said that, the general trend over the past 15 years in, let's say, the proportion of Canadians willing to consider private options, right? So if we kind of pool across all those questions, or if we focus on questions that talk about paying for quicker access as well, for instance, we get a similar kind of a trend. Increasing willingness to consider private options alongside increasing concern about the future of the healthcare system. Basically, as people become more concerned about the future of the healthcare system, they become more willing to consider private options. And at its let's say at its height, interest in private options in Canada is about a 50-50 split. That is about 50% of the population clearly opposed to most forms of privatization, and about 50% willing to consider the privatization. That's one of the reasons why I'm arguing that it's important for policymakers to consider not just current attitudes about the system, but attitudes about the system in the future, because the kind of ongoing public support for the existing Canadian healthcare system is partly dependent on their attitudes about the future. And that ongoing public support can come in the form of responses to questions about support for the existing system, but it also comes in the form of increasing or decreasing willingness to consider serious change.
Great. Thank you, Stuart. We have another question here directed toward Stuart. You had mentioned the disparity between people's personal view of the healthcare system and the system level view, past and future. Given that large segments of the population only make cursory use of the healthcare system, and certain segments make higher use, like seniors, youth, do you have any data on the perceptions of the system for these hardcore users, those who are using the system more, say, than those who are using it less?
That's interesting. We actually find that people who use the healthcare system more, on average, I mean, these are kind of average trends, right? So we generally find that people who use the healthcare system more are more pleased with the healthcare system. Now, that's partly because the people who use the healthcare system more tend to require more than just a visit to a GP or a wait in an emergency room. And so they're moved on to the next level of care. Whatever that next level of care is, and generally speaking, the quality of care as you move beyond, let's say, waiting in the emergency room, in the emergency waiting room, the quality of care improves. So the increased use, the fact that increased use leads to greater support is a product probably of those with who use the healthcare system a lot, actually using different parts of the healthcare system than people who use it less. The people who barely use the healthcare system, they're trying to get an appointment with their GP every couple of years, or they're showing up at an emergency room with their kid every 3 years.
Thank you. Ian, a question here, I think, for you. What influence will the public's negative attitudes toward healthcare have for future public policy development, especially public policy addressing our aging population and long-term care?
Well, I think there's going to be, let's say there's many, at the outset I should say, I think that for the issue to become salient enough to drive relatively public debate again, we're going to have to move to levels of dissatisfaction with the system that we saw again in the late 90s and early 2000s, early years of the 2000s. I think as numbers return to the right ends of the graphs that Stuart showed us earlier, I doubt there's probably enough there to drive a very public partisan agenda. I'm not talking about a policy discussion amongst think tanks and experts. I'm talking about a partisan dispute during an election campaign between political parties. That requires a certain amount of ground to be prepared, and I don't see that we're there yet. And I'm not sure how long it would take us to get back to that situation. Given the level of federal transfers that are now guaranteed for the better part of the next decade, I can see that probably at the end of that, there's going to be some decisions have to be made that might drive that level of unhappiness up again to the point where this could become a salient issue from the point of view of partisan competition. But I'm not sure that I see the numbers, anything in the numbers that would see concern driving up to the point where you have a difference of view between the parties in a sort of an election context that makes a meaningful difference anytime in the next, let's say, election or two election cycles. That's, of course, the pressures continue to be there both on the demand side and on the financing side. I think insofar as the new federal government view on this is that we're going to provide stable levels of, not particularly desperate levels of financing to the provinces and then stand back for the next 10 years. Not sure that I see this coming back to a federal election campaign anytime soon. There will at some point, however, be a point where we have an election where healthcare matters as a substantial issue. And I think the search again will be for some kind of more or less transparent policy that's comprehensible at the retail level. It may or may not be a guarantee in the sense that we tried to articulate in 2006 and tried to follow up on in government, but something that has that level of clarity to voters, because otherwise a more generic promise about financing or about some kind of service level is background noise in an election. I think voters discount those kinds of promises unless they're very specific and very concrete as being not really germane to the overall performance of the system.
Excellent, thank you. And another question for you, Ian, perhaps somewhat related, but the question is from David. There has been a lot of mention in the media recently about the need or the case for a federal government to play a leadership role in reforming health care. The question is this a comment on the citizenry's trust in their provincial governments to effect reform? And the follow-up question is, what new leadership roles should or can the federal government consider?
On the first side, through back to my earlier answer, as far as a pressing partisan need to respond to those kinds of calls, I think these are calls from, largely fed by provincial treasurers who were upset at the federal announcement that was made on the 10-year plan, or on the 10-year financing framework. And I don't see that that's going to have too much resonance at the federal level one way or the other. I mean, this is a call from experts to other experts that resonates amongst fiscal experts on the health policy side, but I don't see any general pickup in a way that would worry anybody in the federal political system about taking a party position one way or the other on this. What sorts of federal responses are possible? I go back to, I think, again, areas of healthcare delivery that are strongly within federal jurisdiction, where there's a great deal of work to be done, especially on the Aboriginal side. And my understanding is that at the moment the federal government's primary focus on Aboriginal policy is on the educational side, which is fine. There's enough problems to go around in that area. And the focus on education has obviously tied back to the general economic management and labor force development streams that the federal government's been trying to pursue over the course of the past, let's say, year or year and a half. Will the healthcare issue come back in that context? Yes. The Conservative government is an increasingly Aboriginal party in the sense of the core of the Conservative Party's support is increasingly Aboriginal in composition. And at some point, I assume that's going to get to a critical mass where the focus on education is not going to be enough, and it's going to have to go broader.
Interesting. Stuart, a question for you. We know that attitudes can be shaped by predispositions or underlying attitudes such as values, identity, and ideology. Do you have information on how the attitudes you spoke about are connected to predispositions? And to what degree are these attitudes rooted in predispositions?
Oh, we think a fair bit, and certainly the work on that front has mostly been conducted by people involved with the Canadian Election Study, and so I'm a recent member there. But there's an accumulated body of work on that in the Canadian Election Study, and I think the general kind of consensus is that most of our policy attitudes are linked to, on the one hand, a set of kind of demographics, and that's kind of, let's think of that as kind of interests. If you have more money or less money, you have different interests where government is concerned. For instance, it varies by age, by education, and gender, and so on. And then there is this set of kind of underlying predispositions, which I would define in this case as those attitudes related to the kind of the appropriate scope of government and the reliability with which government is able to do things, right? So on the one hand, there's a attitude about whether we should have big government or small government, whether we should have a big welfare state or a small welfare state, and then there's other attitudes about whether you think government generally tends to just screw things up, or whether you think when government tries to do something, they tend to do it right. And those predispositions definitely matter to attitudes about healthcare. I'm not sure the proportion of variance that I would allocate to one set of variables versus another set of variables, but most of the models that we look at when we're interested in the impact of experience or the impact of media, for instance, have control for those other variables in the background. That is, we're interested in building a model of attitudes about healthcare that captures the impact of demographics and interests, the impact of these kind of underlying predispositions, and then the impact of kind of more current inputs.
Thank you. And another question for you, Stuart. This is from Brad at Nova Scotia Health. Are Canadians recognizing the role of the broad social determinants of health in their thinking about healthcare? Or are they still thinking that we need to change that to change the system? We need more beds or doctors and just get people to exercise or eat better. We know we need transformation of the system, and we know the environments in which we live, work, and play have an impact. But Brad is curious to know if you've seen in your public opinion research whether the public sees this as well.
I wouldn't say that I've seen it directly. Certainly to the extent that Canadians are concerned with the social determinants of health, if that's the case, it has had no impact on their concern about the number of doctors and number of hospital beds and wait times, mostly wait times. These kind of broader concerns about social determinants, to the extent that they've sunk in at all, they haven't decreased the other concerns. It's not like people are becoming less concerned about wait times and focusing their attention more on social determinants. And certainly when you ask kind of general questions, kind of open-ended questions about the important issues in healthcare, it's still the case that the focus is on mostly wait times and numbers of doctors, and that has really not changed over the past decade. That said, when you turn to kind of content analyses of media content on healthcare, the proportion of stories in Canadian newspapers on kind of health and wellness topics has increased pretty steadily over the past 15 years. And so there's certainly more information, at least about health and wellness issues, on broader issues about the relationship between inequality, let's say, and health outcomes. We see very, very little of that in media. We certainly see very little of it in public opinion polls, but polls haven't tried very hard to get at those attitudes directly. They don't come up in open-ended questions. It may be if we asked more directly, we would find some interesting results.
Thanks, Stuart. One other question here. This is a point of clarification question from Leslie at St. Elizabeth. She wanted to ask you to clarify, Stuart. You indicate that people using the system more and more are more satisfied. She thought she heard the opposite last night at a Conference Board of Canada event with Andre Picard. And
okay.
So if you could clarify this sense of people who are using the system more are more satisfied with the system, yes or no?
Well, I'm going to say yes. Now, I'm working with very different... this is a completely unsatisfying answer. That's my warning. I'm working with big multivariate models, and they're different from the kind of crosstabs that most pollsters and journalists will be working with, which sounds kind of underhanded, like as in my data are better than theirs. But I kind of mean that. The problem is separating out. So there are really two problems in identifying the actual magnitude of the effect. That is, the effect of using the system more. On the one hand, people who use the system more use different services than people who use the system less. And so a direct comparison is difficult. You're not comparing apples to apples. You're comparing apples to oranges. You're comparing people who go to an emergency room once every 3 years to people who are having surgery and they're admitted into hospitals and they see specialists regularly. They're just fundamentally different experiences. And the healthcare system is better at some of those things and worse at others. Now, there are some people who are seriously ill. They see doctors regularly and they're on long wait lists. That's a separate thing. A long wait list, we know, really matters. So you may actually have things pulling in two different directions. On the one hand, they're taking part in some services that are much better than a hospital waiting than an emergency room waiting room, and they may be waiting for. They may nevertheless still be waiting a lot, and so that may be pulling in the other direction. The other problem, and this is related to this kind of social determinants of health issue, is that people are not randomly assigned to different health conditions. The people who have ongoing health conditions are different from the people who don't. There are economic differences. There are all kinds of socio-economic and attitudinal differences between people who have ongoing conditions and people who don't have ongoing conditions. And so one of the really tough tasks for survey researchers is to try to separate out the effect of system use independent of the part of the system that you're using on the one hand, and then all the socioeconomic things that went into your becoming someone who uses the system a lot or someone who uses the system a little, which is, I guess, a very long-winded way of saying it doesn't surprise me a lot that there are conflicting results out there. Extracting this particular piece of information is actually quite difficult. Thanks, Stuart.
Ian, we have a question here from Stephen. Do you think that systematic government underfunding over time created the context of high wait times and low access to doctors, which means, in effect, that political parties need to take some significant responsibility for actually depressing Canadians' healthcare mood? That's the question. And from this, Stephen, speaking, I'd add a corollary to that, which is what happens then, if you agree with that premise, What happens then when the politicians themselves come back to say, but now we're going to fix it for you?
I think that's a good question, of which I have to say I have no idea. I doubt the impact patient by patient of different modes of management and financing and professional training and managerial deployment at the institution level and so forth is all that simple to determine. I have no idea. All other things being equal, I guess level of financing matters, but I don't think that all other things are ever easily claimed to be equal. So I have no idea. I never saw any evidence that when I was in government that people thought that a massive amount of new federal investment in the system was going to make that much of a difference. That I should say, I didn't see any evidence that voters thought that a massive federal investment would make that much of a difference any more than a massive federal drain out of money was going to make that much of a difference one way or the other. I think we'll see a very imperfect natural experiment in that over the next 10 years, as federal government's given obviously some fairly clear indication of what its federal contributions are going to be over the course of the next 10 years, and we'll see how different provinces react to that. But to the core question, I'm not sure I am in any position to answer that, because I think that's a complicated analytical question that I have no expertise on. But obviously, I think the level of public distrust in the ability of governments to manage complicated systems reasonably competently goes far beyond people's worries about the healthcare system in Canada. It's a more general problem that we had across a whole slew of policy issues that were related to the federal jurisdiction, and which are much more complicated even at the provincial level, where the sort of operational decisions are more closely made.
Thank you. Also, Ian, another question for you. This is coming from Pam. Were there other ideas? This is going back to the 2006 election, and you were talking about where the wait times guarantee and how healthcare was polling in relation to some other issues. The question she has is, were there other ideas tested at that time that polled well at the retail level beyond the guarantee? For example, expanding prescription drug coverage or improving access to dental care for children, that sort of thing.
No, there weren't. And in truth, we didn't have a whole lot of what I would say complete market research on the patient wait time guarantee when we ran with it. There are very peculiar reasons for that. When I joined the platform drafting process for what became the 2006 election campaign at the end of the summer of 2005, we were notionally planning for a spring 2006 election sometime in March or April of that year, and the election came upon us much sooner than we had expected. We lost, I would say, 3 or 4 months of good political staff work by virtue of the fact that we just toppled the government at the end of November instead of in March or April on a budget vote. And so a fair bit of the work plan that we had put together got dumped in the rush to move to an earlier election campaign. That said, we had campaigned in 2004 when I wasn't involved in the policy side of the campaign team at that point. I had an operational role for the 2004 election campaign. There was a drug coverage plank in that platform that we had tried to draw attention to, largely as a defensive measure against the attack on the hidden agenda. And every assessment I had seen after the election campaign was that had no pickup of any kind. That people either weren't aware that we had mentioned this drug coverage issue, or they had heard of it but couldn't explain it, how it would affect them, or they understood it, could explain it, but it had no impact on blunting any of the attacks about the Conservative Party having a hidden agenda about healthcare and a whole variety of other things. I think it was just, in effect, not part of the salient policy debate during the course of that election campaign.
Very interesting. Thank you. Stuart, we have a question from Alan. Following the federal position on the 2014 Accord, the three most western provinces seem interested in the innovation and transformation opportunity that this provides. That is, provinces working together to innovate and transform their systems. What do we know from your research about the public mood supporting transformation initiatives in healthcare?
That's a tough one. We have we have an accumulated body of kind of individual questions about individual types of transformations, right? Mostly related to the big questions, like, do you think it's important to reduce wait times, or do you think it's important to get more doctors, or related to issues of privatization. I don't think we have a sense for I don't think we have a sense for kind of openness to reform generally. We can kind of interpolate and say, well, people are increasingly concerned about the future of healthcare, and that concern about the future of healthcare probably makes for a public more willing to consider other options, right? So I'm I'm extrapolating from what we know about willingness to consider privatization options, right? So the more concerned we are about the future, the more we become willing to think about user fees, the more we become willing to think about privatization. I suppose it would be reasonable to argue that actually the more concerned we are about the future, the more open we are to any kind of policy innovation, the more welcoming we are of efforts to change the system, and the more willing we are to consider those changes. But that's, at this point, mostly guesswork, right? I'm kind of basing that on questions that are vaguely related to this issue, not directly.
Thank you. And another question for you, Stuart. When you do a poll and the kind of public opinion research that you've been bringing to us today, do you ask respondents for their level of knowledge of the healthcare system? And do you think this makes a difference for some of the questions that you ask?
We don't know how to get at levels of knowledge very well. There's a whole industry in political psychology and political behavior about how you capture knowledge. Particularly around just general political knowledge. And there are ongoing debates about how you capture just a general political knowledge, and then how you capture specific policy knowledge. So you can ask factual questions and see if people come up with the response, or you can ask for self-assessments of knowledge, and both are tough. Self-assessments of knowledge are, for the most part, unreliable. People tend to certain types of people tend to overestimate their knowledge of things. And so that makes it kind of problematic. And then the factual questions, it's very hard to get at the right set of factual questions, right, that taps into the right kinds of information people need to have. You can ask on health and wellness issues, there you can get at knowledge relatively easily. But on what people know about kind of healthcare policy and what people know about the healthcare system, getting at knowledge is pretty tough. So that's a long-winded way of saying we do sometimes try to get at knowledge generally in the surveys that I've been involved with, but knowledge of the healthcare policy in particular is much tougher. Often we use experience as the surrogate, as in how much someone has used the healthcare system as a measure of how much knowledge they would have of how the system works, but that's imperfect.
Mm-hmm. Thank you. Ian, you mentioned that prior to the 2006 election, there was a trust deficit, I think was the word that you used, around, the current federal government at that time, which was in opposition, and vis-a-vis, say, the Liberals who were then in power. So we have a question here from David which says, in talking about this trust deficit that applied to the federal government back in 2004, 2006, etc., and their ability to reform, health care. Do you think this has lessened over time, over the last 6 years as the party has been in power? And do you believe that there's more trust now in this federal government to reform the system than there was before, or at all?
Let me just say, Stephen, first of all, that since I left the Prime Minister's office in July of 2008, I haven't seen any of the party's internal polling on this, and really the only complete data set, there are no complete public data sets available on this in any systematic way. The only source for this would be the party's internal polling. So I'm guessing here based on very, very, very inadequate episodic efforts by polling companies to produce stuff that's of interest to some newspaper's front page that contains something similar to this information. So my plus or minus 19 times out of 20 here is very high.
Okay.
My guess is probably not. Those sorts of attributes of the various parties amongst members of the voting public, generally speaking, don't change much over time. So, for example, if you look at some of the recent polling that asked people to describe over the course of the past year, words that you would attribute to the various parties, the Liberal Party still carries both negative and positive assessments in these sort of fragmentary polls that I've seen that would reflect everything I saw from the party's private polling in 2005, 2006, 2007, 2008. And even between 2006 and 2008, people's core perceptions of what you could trust the Conservative Party on and what you couldn't trust the Conservative Party on didn't change that much, even over the course of 3 years in government. And I'm not sure that I've heard from anybody that has changed remarkably since I left. This has a very small amount of public information that's available here. Doesn't lead me to believe things have moved that much. I think what has happened is that people's, sensitivity to problems about health, have gone up or down over time, and so insofar as economic and other sorts of similar issues that are top of mind issues today, there's no question that it plays to perceived core competence of the Conservative Party vis-a-vis the opposition parties, and the Conservative Party wins the benefit every time that's a top of mind issue.
Thank you. It's very insightful. This one could be directed to either of you, but it looks like ultimately Stuart. Both Stuart and Ian return repeatedly when discussing Canadians' attitudes toward the healthcare system to wait times and access to family physicians, events that are experienced at the personal level. Yet Stuart has pointed out that media appear to have a significant influence on attitudes about healthcare at the extra-personal level. How best, according to Stuart, might Canadians be informed about non-personal or system-wide aspects of the healthcare system, such as challenges with coordination of community services, transitions in care as we move from acute care to long-term care to community care, etc.? Stuart, how best do you think people, to what extent do they understand those system-wide issues, and how do they tend to create their opinions of them?
Well, I mean, this kind of extra-personal experience is what we're almost invariably talking about is media content, and note that, there's a tendency when we talk about media effects to think of it as journalists writing something which paints a particular picture, or let's say a biased picture of the system, and so public opinion is swayed in this biased way, and that's what a media effect is, as in it creates a public opinion based on something that's not real. But that isn't what I mean by media effects. I tried to talk about that a little at the close of my presentation. What I'm talking about is information that comes to people through media. It could be totally correct, and I allow for that possibility. I suspect actually that a lot of what people are learning from media right now is accurate about the healthcare system. That is that they're increasing wait times, or that there are continuing problems, at least with wait times, and continuing problems with numbers of doctors. That's probably accurate, and they're getting it from media. And so the best way really the only way for people to kind of get a sense for this kind of extra personal experience is going to be through media content. So then the issue for healthcare policymakers is how best to deal with media content. That is, how best to get the important information, that is the information that healthcare policymakers think is important, into media so that people can learn about it. And there's a whole industry, of course, around that as well. That's quite tough. But that is basically, in the end, that is what I'm talking about in terms of policymakers and this kind of extra personal experience. It's about recognizing that healthcare policymaking is partly a policy effort and partly a communications effort.
Right, exactly. I think we've heard a lot about that today on this call. Unfortunately, we are not going to be able to get to any more questions. We're pretty much out of time. We appreciate the questions that have come in, and we'll try to get those to our speakers after the call. If you are interested in reading Stuart's report, then please go to our website, which is www.chsrf.ca, and you'll find Stuart's paper and his synopsis of Canadians' attitudes on the website there. A reminder that our next session of On Call is on June 13th, where we'll have Livio Di Matteo from Lakehead University, who did modeling out of the sustainability of Canada's healthcare systems, all of the provincial systems through to 2030, and found some discouraging results. And Don Drummond, who will be responding with Livio on that call, who recently, of course, did the major report for the Ontario government on the sustainability of healthcare in Ontario, as well as government services in Ontario. Registration details and more information on future on-calls and the full on-call lineup can be found again on our website, chsrf.ca/on-call. We'd also encourage those of you who have not signed up for our electronic newsletter to do so. It's at CHSRF, and then you can stay up to date on all of the activities here, including future calls. At this time, I'd like to thank very much our two speakers this afternoon, Stuart and Ian, who for just an excellent talk today on an issue that is always around the top of Canadians' minds when they're thinking about public policy issues, and some very interesting nuances about what that means when we say that's on the top of Canadians' minds. Thank you both for being with us today, and thank you to all of you who joined us on call.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.